Good day. We're going to discuss about neurologic exam. The neurological exam begins at the onset of the interview. Indirect observation of the child's appearance and movements can yield valuable information about the presence of underlying disorder. Second, the child's behavior while playing and interacting with his or her parents may also be telling. The examination should be conducted in a non-threatening, child-friendly setting. The child should be allowed to sit where the child is most comfortable, whether it be on a parent's lap or on the floor of the examination room. The physician should approach the child slowly, reserving any invasive or painful tests, example, measurement of head circumference, gag reflex for the end of the examination. For the assessment of the newborn, we must observe the body posture and movement. And for the head, correct measurement of the head circumference is very important. It should be performed every visit for patients younger than 3 years old and should be corrected and recorded on a suitable growth chart. To measure, a non-distensible plastic measuring tape is placed over the mid-forehead and extended circumferentially to include the most prominent portion of the occiput. For the inspection of the head, we must check the size, shape of the head, and symmetry, and observe the venous pattern. In palpation, we might reveal bony bridges between sutures, such as craniosynostosis, cranial defects, or in premature infants, softening of parietal bones, such as craniotabes. Newborn skull characteristically reveals molding of the skull accompanied by overriding sutures. For the auscultation, it is a very important adjunct to the neurologic exam. Cranial bruit may be noted over the anterior fontanelle, temporal region, or orbits, and are best heard using the diaphragm of the stethoscope. It is very important to assess the cranial nerves, starting from cranial 1 to cranial number 12. Cranial number 1 olfactory nerves cannot be examined in newborn. Cranial number 2 optic nerve, we use a pen light and you shine the pen light on the eyes. For cranial nerves number 3, 4, and 6, oculomotor, trochlear, and abducens, it is assessed simultaneously. We do it by elevating the head of the baby 30 to 45 degrees angle. For cranial number 5, trigeminal nerve, we do corneal reflex and chin tap. For cranial nerve number 7, facial nerve, note for symmetrical facial expression and let the baby smile or cry. Cranial nerve number 8, vestibulocochlear, we test acoustic blink reflex. For cranial nerve number 9 and 10, we do it simultaneously by doing gag reflex. Cranial nerve number 11, spinal accessory nerve, we shrug the shoulders of the newborn. And cranial nerve number 12, hypoglossal nerve, pinch the nostrils, observe reflex opening of the mouth with tip of tongue to the midline. Born neuro exam. So what are we going to assess first is the posture of the baby. Next, we must assess the ability of the patient for flexion and extension. Flexion of the upper extremities, flexion of the elbow joint, and flexion of the wrist. Flex the lower extremities and the knees and ankles as well. This is an actual example of how to flex and extend the lower extremities. The other thing to take note is the hand. You can see that it can be easily opened or grasp your hand. Next is the posture of the head and neck. Usually, in the newborn, we will have the neck turned into one side and to the other side. Next will be the activity. What are the spontaneous activity you should take note? The spontaneous playing of the hand and feet of the newborn. If you notice that one side of the body doesn't move, it tells you that the baby has one side paresis. And lastly, we measure the head circumference several times using a tape measure. It is important neurological exam to assess head growth, assess rate of growth of the cranium and the brain. We measure the head circumference over the glabella and supraorbital ridges anteriorly and part of the occiput posteriorly. We do this 3 times and get the average. The birth head circumference is 35.5 cm or range from 33.5 to 36.5 cm or 14 inches. At 6 years old, head circumference is almost the same as the adult. Now, let's assess the cranial nerves. Cranial nerve assessment. Examination of the baby's cranial nerve function is often accomplished by observing spontaneous activity. Assess the cranial nerve number 2 by checking the response of the baby to light. For cranial nerve number 3, this nerve is responsible for pupil size and certain movements of the eye. Your child's healthcare provider may examine the pupil, the black part of the eye with a light, and have your child follow the light in various directions. Cranial nerve number 3, 4, and 6 are tested together, since cranial nerve number 4 helps the movement of the eye in combination with cranial nerve number 6. It can be assessed by using vestibulo-ocular reflex, Dahl's eye maneuver. When the head is turned, there is a conjugate eye movement in the opposite direction. You can do it by moving the patient's head side to side horizontally.
Good. They're together. We can even do that in the vertical direction. Okay. You see the Dahl's eye maneuver is normal.
For cranial nerve number 7, check the response of the baby to the sound. Sucking and swallowing assesses cranial nerve number 5, 7, 9, 10, and 12 because all these cranial nerves are involved in this complex act. Newborn motor exam. Motor exam examine muscle bulk, muscle tone, and muscle strength. For the muscle bulk, you must check for atrophy, decreased muscle bulk, disuse, diseases, and check for hypertrophy, which is increase a muscle bulk physiologically, or pseudohypertrophy, which is a muscle tissue that has been replaced by fat and connective tissue. Check for abnormal movement such as fasciculation, tics, dystonia, chorea, and athetosis. Muscle tone, it is generated by an unconscious, continuous, partial contraction of muscle, creates resistance to passive movement of a joint. Tone varies greatly based on a patient's age and state. There are 3 key tests for assessing postural tone in neonates, such as traction response, vertical suspension, and horizontal suspension. For traction response, grasp the infant's hand and gently pulls the infant to a sitting position. Normally, the infant's head lags slightly behind the infant's body and then falls forward upon reaching the sitting position. For the vertical suspension, first, nods the infant by the axilla without gripping the thorax. Second, the infant should remain suspended with the infant's lower extremities held in flexion. If an infant is hypotonic, it will slip through the physician's hand. Last is the horizontal suspension. Hold the infant in prone position by placing a hand under the infant's abdomen. The head should rise and the limbs should flex. If the patient is hypotonic, it will drape over the physician's hand, forming a U shape.
For the motor examination of the baby, first, we check for the muscle bulk to see if there is atrophy, hypertrophy, and/or pseudohypertrophy. We check also if there is any abnormal movements such as fasciculations, tics, dystonia, chorea, and athetosis. Next is, we examine for the muscle tone. For traction response, hold the hand of the baby from the supine position and gently pulls the baby to a sitting position. Normally, The baby's head lags slightly behind the baby's body and then falls forward upon reaching the sitting position. For the horizontal position, hold the baby in prone position by placing a hand under the infant's abdomen. The head should rise and the limbs should flex. If the baby is hypotonic, it will drape over the physician's hand, forming a U shape. For the vertical suspension, hold the baby by the axillae without gripping the thorax. The baby should remain suspended with the baby's lower extremities held in flexion. A hypotonic baby will slip through the physician's hand.
Good day. So in older children, a complete neurological examination may be done as in adults. It begins at the outset of the interview. The examination should be conducted in a non-threatening, child-friendly setting. The child should be allowed to sit where he or she is comfortable. Let's start with the mental status examination. This is to assess the child's level of awareness and interaction with the environment. This includes consciousness, attention span, orientation to time, place and person, memory, recent and remote, fund of information, insight, judgment, and planning and calculation. For children older than 3 years old, we can ask them to draw a picture or copy objects and then discuss their picture to test simultaneously for fine motor coordination, cognition, and language. Among school-aged children, the best test for the development is their school performance. We can obtain school records or psychological testing results. Motor examination. Motor examination should include gait and posture, muscle bulk, tone and strength, coordination, deep tendon reflexes, and pathological reflexes. Initial appraisal for motor system begins as we take the history. Here, we could check the patient's posture, general activity level, tremors, and any involuntary movements. For muscle bulk, inspect the size and contours of muscles. Inspect for asymmetries, fasciculations, tremors, and any voluntary movements. To check for muscle tone, ensure that the patient is relaxed and assess the tone by alternately flexing and extending the patient's elbow and wrist. There should only be minimal resistance to the wrist. Then in assessing the muscle strength, it is tested by having the patient resist the pressure from the examiner and then report the patient's muscle strength based from this grading. Next, to test for the patient's coordination, we can do the following test. First is the heel to shin test. Here, the patient places her heel carefully on the opposite knee and slides it slowly. Ask the patient to repeat it several times and observe for difficulty in coordination. Rapid alternating movement. Ask the patient to pat her hand as rapidly and regularly as possible. Observe for difficulty and coordination. Finger to nose test. Ask the patient to alternately touch her nose and the examiner's finger with the tip of his or her index finger. Check for dysmetria and any involuntary movements. To check for the gait, ask the child to walk on heels and toes and do tandem gait. Note for asymmetry, weakness, clumsiness, and undue tripping. Romberg's test. Here we ask the patient to stand with her feet together and eyes open, and then close both eyes for 30 to 60 seconds without support. Note the patient's ability to maintain an upright posture. Normally, any swaying is minimal. Sensory examination. A complete examination includes evaluation of touch, pain, temperature, joint position sense, and vibratory senses. We should always compare one side with the other. To test for light touch, place a cotton wisp and pin on the hands, feet, and trunk. Ask the patient to respond when felt, and then compare both sides. For vibration sense, test vibration sense at knuckles and bony prominences using the tuning fork. Note when the patient detects vibration. Position sense of fingers and toes. Firmly grasp the side of the great toe or of a finger and ask the patient to detect and respond to movements in an upward or downward direction. To test for temperature, ask the patient to close her eyes and respond when felt. The patient should be able to identify which one is warm and which one is cold. Deep tendon reflexes. This includes the ankle and knee jerks, brachioradialis, biceps, and triceps. For the biceps reflex, the patient's elbow should be partially flexed and the forearm pronated with palm down. Place your thumb or finger firmly on the biceps tendon. Aim the strike with the reflex hammer directly through your digit towards the biceps tendon. Observe flexion of the elbow and watch for and feel the contraction of the biceps muscle and then grade the patient. For the superficial reflex, one example of the superficial reflex is the abdominal reflex. We stroke the abdominal wall from outside towards the umbilicus. The umbilicus should move towards the area stroked. Pathological reflexes. This includes Babinski reflex and its other modifications. The Babinski reflex is tested by stroking the underside of the foot. Stroke the lateral aspect of the sole from the heel to the ball of the foot, curving medially across the bulb. Observe the movement of the big toe. Normally, plantar flexion. Another modification is Chaddock sign. The difference is the area of the stimulation. In Chaddocks, we stimulate the dorsolateral aspect of the foot from the posterior part of the skin, just inferior and anterior to the lateral malleolus, and along the lateral edge of the foot. Another one is Oppenheim test. The examiner runs a fingernail along the crest of the tibia. Absent sign means no reaction or toes slightly flexed. Sign present means similar to Babinski sign, toes extend and fan out. A normal response is no reaction. Lastly, meningeal signs. These signs signify meningeal irritation. Here, we test for nuchal rigidity, Brudzinski, and Koenig sign. To check for nuchal rigidity, first make sure there is no injury or fracture to the cervical vertebrae or the cervical cord. Then, with the patient supine, place your hands behind the patient's head and flex the neck forward, if possible until the chin touches the chest. Normally, the neck is supple and the patient can easily bend the head and neck forward. Next, Brudzinski sign. As you flex the neck, watch the hip and knees in reaction to your maneuver. Normally, they should remain relaxed and motionless. Last but not the least, the Koenig sign. Flex the patient's leg at both the hip and the knee and then slowly extend the leg and straighten the knee. Discomfort behind the knee during full extension is normal, but it should not produce pain. That would be all for the neurological examination of older children.
Today, I'm Ransrayan Balabbo and I will be demonstrating the sensory examination and reflexes in newborn. In sensory examination, there is relatively low yield in terms of information that it provides. We perform light touch to the patient with the cotton swab in different areas proximally to distally in each extremities. Normal infants and children indicate an awareness of the stimulus by crying, withdrawing the extremity, or pausing briefly, and this cannot be done repeatedly. For the reflex examination, in infants, we position the head in the midline when assessing reflexes because turning the head to one side can alter the reflex tone. And as for the grading of reflexes, you can see it on the screen. For the deep tendon reflexes, we have ankle jerk reflex, knee jerk reflex, biceps and triceps reflex, wherein ankle jerk reflex is the hardest to elicit. Ankle jerk reflex, we possibly dorsiflexing the foot and then tapping on either the Achilles tendon or the ball of the foot. In knee-jerk reflex, it is evoked by tapping the patellar tendon wherein there is a crossed adductor response. Biceps reflex, the brachioradialis tendon is tapped leading to contraction of the biceps tendon causing deflection of the forearm. While in triceps reflex, the triceps tendon is tapped resulting to the extension of the forearm and contraction of the triceps. We have two types of newborn reflexes, mainly primitive reflexes which is present at certain period but disappears later. And the next type is persistent reflexes which is present at birth until adulthood. After the sudden drop in moro reflex, abduction and extension of both upper and lower extremities, then adduction and flexion of upper and lower extremities followed by crying. In palmar reflex, an object is placed in the palm and the response of the baby is it will grasp the object by closing its fingers. The object is grasped by its hands and extend. In parachute reflex, the baby is held upright and is rotated to face forward as it falls. The baby will extend its arm forward as it would make the fall. In placing reflex, we allow the baby's dorsum of the foot touch the other surface of examining table. The baby will raise its leg as it steps. Walking reflex, the baby is held upright, it touches surface, and the infant starts walking or steps alternative. In tonic neck reflex, face front then turn one side. The response is upper and lower extremities extends on the same side where head is turned, while flexion of the extremities on the opposite side. In plantar reflex, we use an object to touch the sole at base of both toes. The response is the toes grasp or falls around the object. In rooting or sucking reflex, we touch or stroke the cheek of the baby near the corner of the mouth. The response is the head turns toward the stimulant. There's also a sucking movement that enables the baby to take their food. Thank you for watching.
Cranial nerves in older child. Cranial nerve number 1, olfactory nerve. Smell use stimuli like coffee. Each nostril should be tested individually. Your eyes. Okay. Takpan po yung isang ilong. Okay, close your eyes. Inhale. Okay, kabila po. Cranial nerve number 2. An older child should be placed in the patient's lap and should be distracted by bright color object. The color of optic nerve is salmon pink. Next is check for visual acuity. Let a toddler read the Snellen chart. Do it in both eyes. Cranial 3, 4, and 6 are tested simultaneously. This muscle and nerves can be assessed by having the patient follow an interesting toy or the examiner's finger in the 6 cardinal direction of gaze. For cranial nerve number 5, trigeminal nerve, it can be assessed by corneal reflex and nasal tickle, mastication, and jaw jerk. Ask the patient to close her eyes. Ask the patient if she felt a sensation in the ophthalmic, maxillary, and mandibular area. Next. And lastly, check the ability of the patient to differentiate soft and sharp touch. You can move your chin side to side. Say ah. Cranial nerve number 7, facial nerve, is ask the patient to mimic a series of facial movements like smiling, inflating the cheeks, raising eyebrows, place a solution of saline or glucose on one side of extended tongue. Margot, you copy mommy. Smile. You raise your eyebrow. Both of them. Like this.
The 8th cranial nerve or the acoustic nerve has two divisions. For the cochlear division, we can test auditory acuity by doing the finger rub test on both ears. We can further test that by doing the Weber-Riney test. Test uses a tuning fork that is then placed in the forehead. We can then ask the patient if he or she hears it on one side, the other, or the middle. Lastly, for the Riney test, we can strike the tuning fork and then place it on the mastoid bone behind one ear and then ask the patient to signal us when they can no longer hear the sound. Once they can no longer hear the sound, then we can now move the tuning fork next to the patient's ear canal. And then once again, ask the patient to signal when they cannot hear the sound anymore. And then we repeat it again on the other side.
For the cranial nerve 9 or the glossopharyngeal nerve and cranial nerve 10 or the vagus nerve, the examiner should observe the position and symmetry of the palate and uvula at rest and with phonation. For the gag reflex, depress the patient's tongue and touch the palate, pharynx or tonsils on one side until the patient gags. Compare on each side. For the cranial 11 or the accessory nerve, check shoulder shrug or the trapezius muscle and head rotation to each side or the sternocleidomastoid against resistance. Weakness of head rotation and shoulder elevations are signs of dysfunction. For cranial nerve 12 or the hypoglossal nerve, observe the position of the tongue at rest with mouth open and during protrusion. Inspect for atrophy, fasciculations, and or deviations.